My pleasure to introduce our presenter, Dr. Andrén. He's a clinical psychologist and postdoctoral researcher at Lund University, Sweden. His thesis from 2022 is on behavior therapy for Tourette's, specifically for internet-delivered treatment and primarily ERP. He's also one of many authors of the recently updated European Clinical Treatment Guidelines for Tourette's. Thank you, Dr. Andrén.
Thank you very much, Julia, for this introduction and for inviting me to present to all of you. I think we'll just get to it. There are two parts of this. One is today, and the other one is next month, if I remember correctly. So if I'm not able to answer everything today, then we can catch up the last questions and such in the next presentation. So this will be part one of exposure and response prevention, and then obviously part two will follow. And it all says Karolinska Institutet on these slides. It's my previous university. I just moved to Lund University, and also in Sweden. So the slides will be available. Julian will send them out to you. We will have about 50 minutes presentation now, and then we will leave about 10 minutes for questions. And then you should also fill in this the poll after the presentation. And I know many of you need to leave exactly at the minute, so I'll try to keep the time here. So for part one today, we will go through diagnostic criteria and characteristics of tic disorders. I will talk about treatment guidelines and what is recommended. And then we will dive into exposure and response prevention. Also, it's abbreviated as ERP, and we will do part 1 out of 2 today. And then there will be room for questions. So let's start with the diagnostic criteria and characteristics. So looking at the DSM-5, a tic is described as a sudden, rapid, recurrent, non-rhythmic motor movement or vocalization. The onset need to have been before 18 years of age, and the tics it needs to have been persisted more than 1 year since the first tic onset. So if that is the case, then the following diagnoses are possible. Or actually, the first diagnosis is when tics have not persisted more than 1 year. So if it has persisted less than 1 year, it's nowadays in the DSM-5 called provisional tic disorder. So it might be that it will go away, or it might be that the tics will persist, and then the patient will fulfill criteria for one of the 2 following diagnoses here. So either the persistent motor or vocal tic disorder, also called previously referred to as the chronic motor or vocal tic disorder. So that diagnosis is if you've had motor tics or vocal tics during this period, but not both categories. As soon as you've had both categories and more than 1 motor tic and at least 1 vocal tic, then you fulfill criteria for the diagnosis Tourette's disorder, or also commonly referred to as Tourette's syndrome. So Tourette's syndrome, it does not mean that you need to have any specific tics like swearing or something like that. It just means that you've had motor tics and vocal tics, and it's persisted for more than 1 year, and the patient has been the onset was before 18 years of age. So a little bit about the characteristics. So we talk about motor tics and vocal tics, starting with the motor tics. So common motor tics are eye movements, blinking with the eyes and similar, nose twitching, facial grimacing, and other movements in the face, head jerking, jumping, and touching objects. The list is longer. It could be there are many examples of tics, but these are some of the more common ones to look for. And vocal tics could be, it's actually a better description of vocal tics is actually phonic tics, because it's not just tics that comes from the mouth, like vocally expressed. It could also be sniffing and similar sounds created by the nose rather. So, but here the examples I listed was coughing, throat clearing, sniffing, as I mentioned, grunting, echolalia, that is repeating what someone else is saying or repeating what yourself is saying, and coprolalia is the swearing and saying obscene words. And then there's another division here, and we have motor tics and vocal tics. That's part of the diagnostics, but then we also have a division which is more kind of for clinicians, and a division into simple tics and complex tics. So it's kind of like a gradual spectrum in a way, where simple tics are brief, they involve a limited number of muscle groups, and while complex tics are more, it could be for tics which has a little bit of a prolonged duration, coordinated patterns of several tics or several simple tics, could involve several muscle groups, and could also appear to be bizarre and perhaps also appear to be a little bit voluntary, seem to be voluntary, even though they're not. Another thing I would like to mention here is another characteristic is the premonitory urges, also referred to as tic alerts and tic signals. These are sensations preceding tics, and these are sensed by most patients, but perhaps not all patients, and at least not some of the youngest patients youngest individuals may have difficulty describing these, or may not actually sense these, but for most older and adult patients, these premonitory urges are described, and so this awareness seems to increase with age, and these premonitory urges, they're usually bothersome. They're kind of like a ticky, itchy feeling in the body, and something the individuals do not like to feel. So these premonitory urges, they are an urge to perform tics, so they're kind of alerting that a tic is about to happen. And here are some examples of how they have been experienced by I think mainly by younger individuals, kind of like a tension or pressure energy inside the body. That might also be a description by an adult, but otherwise kind of like an itch, or like you're about to sneeze, or for younger children, perhaps that small insects are crawling inside the skin, or that a volcano is about to erupt. So usually bothersome sensation that is felt by most, but perhaps not all individuals experiencing tics. See if we can move on. A little bit about prevalence. It's a little bit uncertain, and it depends a little bit on what study you're looking at and what the criteria were in that specific study. But for Tourette syndrome, approximately 1% of the population, and the persistent motor or vocal tic disorder, from about half a percent up to 3%, depending on which one, and it's definitely more common to have only motor tics than to have only vocal tics. And then there's provisional tic disorders, and some studies claim to up to 20%. But this is very common in younger children, a certain age, around 4, 5, 6 years, and then usually go away for many of these individuals for within a few months. So do not persist beyond the mark of that 1 year mark, which was important for the diagnostics. A little bit about the development and the course. Onset is typically between ages 4 and 6 years. That's a very common age of onset, and the peak severity has been described around the ages of 10 to 12 years or such. And it's important to be aware that, and it's also described actually in the DSM-5 criteria, that tics wax and wane in presentation and severity over time. So that is a characteristic of tics, and also something to look for when you're doing your differential diagnostics. That tics should not be a stable, the same move, jerk, or same sound each day in the same way. It usually waxes and wanes in severity, and also which tics are presented during which periods. Tics are most common in boys, about a 3:1 or 4:1 ratio. And tic severity usually decreases during late adolescence. So if you interview adult patients, adult individuals, they describe and report less tics than they would have reported when they were 5 or 7 years younger or so. A little bit about risk and prognostic factors. Tics seem to increase by environmental factors such as anxiety, excitement, and that could be positive excitement, that's doing something fun or really exciting, and could also increase by exhaustion and by stressful events. And on the other hand, tics seem to decrease by during calm and focused activities. It seems that both genetics and environmental factors play a role, but there are without a doubt quite, I would say, very clear genetic factors in this. Tics seem to run in families, and especially among from males to males within families. But also there's some environmental factors here that it has in epidemiological studies. It has shown that increased tic severity are associated with older paternal age, lower birth weight, maternal smoking during pregnancy, obstetrical complications and such. I would not draw too much conclusions from this. They're observational correlational studies, but it should be known, to sum up, as in most psychological and psychiatric diagnosis, we don't really know exactly what is causing this. It's probably a mix of both the genetics and the environmental factors. A little bit about the functional consequences of tic disorders for the individuals. Obviously, these tics seem to cause psychological distress, but also individuals also report physical pain or injury. Attention difficulties from having these tics, that they kind of disturb the attention. It's also commonly reported sleep difficulties, and then as maybe a little bit face valid is that it comes with a social isolation, kind of interpersonal conflicts and peer victimization, that it kind of having these kind of jerks and movements may cause some difficulties in interpersonal relationships and similar. And in some cases, it also may cause social avoidance as a consequence. And looking at epidemiological studies, we've conducted a few of these here in Sweden. And one of them has found an association with limited academic prosperity, actually at all levels, from early school life up to university, and also in associations with higher suicide risk. So there might be some other more long-term consequences as well, apart from the more direct consequences that is the first 6 bullet points here. All right, so that was a little bit of a quick overview. I'm aware it was a little bit rushed, but I guess many of you have different backgrounds, and I just wanted to make sure that we're on the same page now with the basics before moving on to more treatment-focused information for the remaining part of this presentation today, and also the presentation the next month. So, moving on now to the treatment guidelines for Tourette's and other tic disorders. So these are the North American guidelines published by the American Academy of Neurology, and with the first author, Tamara Pringsheim, which is a colleague to Julia. They were published in 2019, I believe. And here is one part of the European clinical guidelines, which I was part of authoring, and this was published in 2021. So both of these guidelines, they more or less say the same thing if we're going to condense it. They say that psychoeducation, that is education about tic disorders and what Tourette's and tics are and similar. It's recommended as the first intervention for all patients, regardless of symptom severity. So everyone should get that. Everyone that gets a diagnosis or has tics should get this basic psychoeducation. And then when psychoeducation is not enough, then behavior therapy, which I will abbreviate as BT, is recommended. And the reason for this being recommended prior to medication is more or less only that it's believed to be associated with fewer side effects compared to medication. But apart from but it's also important to notice that medication is an evidence-based treatment option, and it's really helpful for the severe end of spectrum of patients with individuals with really severe tics. Medication can be very helpful. So how do we then know who should get the medication, who should get BT, etc.? So it's just not the severity factor. It could actually be there's several factors that are involved and contribute to the treatment decision to I mean to offer behavior therapy or medication for a specific individual. So it could be age, symptom severity, comorbidities, tolerance of side effects, patient preferences, and of course also availability, because it has shown that even though behavior therapy is recommended in guidelines, it is not very widely available in many parts of the world, and it's usually limited to larger cities and people being specially educated in these treatments. So there's a lack of treatment providers, and then a limited availability overall. So we will not talk more about medication today. We will move on now to behavior therapy, BT. I'm not talking about CBT today, cognitive behavioral therapy, because there's not so much C in this. There's not so much that we're working with the cognitions. So I will just talk about BT a little bit simplified. So BT is based, BT for Tourette's and other tic disorders, based on the assumptions that tics have a neurobiological origin, but that their expression is influenced by environmental factors. So if this wasn't the case, then obviously we would not be able to work with kind of like a neurobiological condition with a behavioral intervention, obviously, because then it would not have worked at all. So this is kind of like the basics. We know that it's kind of has this origin, but despite that, it seems that we can actually affect the expression by environmental factors and by behavioral strategies. So that is the goal, what we want to do. And out of these various types of behavioral strategies, there are most evidence for two modalities, and one is called habit reversal training, abbreviated as HRT, and the other one is exposure and response prevention, ERP, which I will mainly be talking about today. So a little bit about the evidence for these treatments, so you know if I'm just making this up or if this is something that should be recommended, etc. So if we look at HRT, and which commonly in North America is referred to as CBIT, it's called the Comprehensive Behavioral Intervention for Tics, of which HRT is kind of the main part of this kind of, it's kind of like a package of various interventions for tic disorder. So there are two large randomized controlled trials that the guidelines are mainly based on. They were published by John Piacentini and colleagues and Sabine Willem and colleagues in 2010 and 2012. And they show that this treatment, HRT-CB treatment, is more effective than more efficacious than a control condition, which consisted mainly of psychoeducational materials. And I'm not sure how familiar you are with these kind of effect sizes, but these effect sizes were around 0.5 to 0.7, so they were in the medium. They were medium-sized. Moving on now to ERP. So there's pretty good evidence. These are two large, very well-made studies, and there's other studies as well, but these are the largest for HRT CBIT. So there's pretty good evidence for these treatments. Moving on now to ERP. There's only one RCT of face-to-face ERP has been published, and in that study, ERP was compared to HRT in a sample of both children and adults. And in this study, they were not really compared against each other. Instead, they just concluded that both groups improved. So little less evidence for the face-to-face ERPs. Not so many studies have actually been published on that. Now, recently, there are two large RCTs published on ERP, but they are on internet-delivered ERP. And I was involved in both of these studies, and I will show some slides of them briefly in the next presentation in next month. But I can say already now that in one of these studies, the UK study, ERP was superior to the psychoeducational comparator. A little bit smaller effect size than in the CBIT studies above, but this was also partly as self-help treatment. And in a Swedish study, which I was involved in mainly, we actually was not able to replicate this finding. We found a good improvement in both groups, so they improved also in the psychoeducational group. So this kind of confuses things a little bit, but I will talk more about that in the next presentation. But so, summarizing here, there are good evidence for CBIT, little bit less evidence for ERP, but many clinicians and researchers and also the writers of these guidelines kind of concludes that both are viable treatments. And the American treatment guidelines, they mainly recommend HRT CBIT, while European guidelines recommend both these treatments. These recommendations are based on the same clinical trials, so it's only the interpretation of the significance of the study results that differ. So it's a little bit split. It's more popular with HRT in North America and definitely more popular with ERP in Europe. So I'm not really sure how it ended up like that, but that is my impression of working in this field. So despite these being two different treatments, they are actually pretty similar if in my view, if you look at what these treatments actually include. Both treatments, HRT and ERP, they instruct the patients to suppress or resist or stop their tics. And in addition, the patients are also instructed to focus on their premonitor urges while suppressing the tics. So the kind of basic foundation of both treatments, they're actually the same. Focus on the premonitor urge and try to refrain from ticking. But then the strategies for how the patient should suppress their tics, they differ, at least partially, between these treatments. So in HRT CBIT, the individual is instructed to suppress one tic at a time using a so-called competing response. So that is a physical behavior that is incompatible with expressing a tic. It could be like folding your arms if you have an arm flapping tic. So fold your arms, keep holding your arms folded so you're not able to jerk with your arm. And in ERP, the individual is instead instructed to suppress all tics at the same time, not working with one tic at a time. And then they're not instructed to use any of these competing responses. They're just trying to use their mental power to feel that the premonitor urge is coming, and when they feel that the premonitor urge is there and a tic is about to come, they just try to not let out the tic. If you want to read more about both HRT, CBIT, and ERP, these manuals are available. And even though it may sound like I'm presenting something new here, these manuals have been around for, as you see, 10, 15 years already. And despite this, we're still working on trying to spread these treatments more And as I said, they're not readily available. The left manual, I'm pretty sure you will find in Canada. But the right manual, I know it's available on the Amazon in Europe, but I'm not sure if you can find it in North America easily. But the right manual also has parts about HRT, but it's also a separate manual about ERP if you're interested in reading more. So look around. If you can't find it, send me an email and I can forward you to the authors, and perhaps they should make this manual more available. So 2 manuals. All right. So that was a little bit about the treatment guidelines about both CBIT and ERP. Now moving on then to the focus of today's presentation and also next month's presentation, which is exposure and response prevention. So I've already mentioned a little bit about this. Obviously, the focus here is that we want the individuals to practice to suppress their tics and to suppress all tics at once. So there are 2 main components in ERP. One is the response prevention, and one is the exposure, obviously, as we hear. So let's look a little bit closer on what these components include. A little bit about the rationale first. This is a rationale which may be explained to a patient, an individual with tic disorder. So when you're presenting the ERP treatment, to get them to understand a little bit closer on why they're supposed to do this treatment. So if we focus here on the premonitor urge here, hopefully the patient individual may recognize the premonitor urge, and what they usually do as a consequence of the premonitor urge is to let the tic out, because the premonitor urge is an unpleasant feeling, and you don't want to have an unpleasant feeling, so you let the tic out, and then the unpleasant feeling disappears. But this is just a temporary solution, and this is what in CBT language would be called as a negative reinforcement. That the ticking is negatively reinforced by the unpleasant premonitor urge goes away, and so the individual is kind of stuck in this vicious circle. So what we want to do here is that we cannot do much about the premonitor urge. It will be there, probably continue to be there. We can't do much about it, but we can try to teach the individual to refrain from letting the tic out, and then we hope as a consequence that we will kind of break this vicious circle by breaking it already here in the second part of it. When you present this treatment for an individual, most patients might say, from my experience, many say that they can already suppress their tics for at least a short period of time. This is not something new you're coming with. So the new thing you're introducing here is not that you're teaching them to suppress their tics. It's more that to teach them to practice to do this systematically in a way that so they actually increase their possibility and to do this and to do it for longer and longer periods of time and similar, and in specifically difficult situations where they have difficulty suppressing the tics. It is not certain whether patients habituate to the unpleasant premonitor urges when performing ERP. I mean, if you look in the top right corner here, if you're used to working with anxiety disorders or so, you might be drawing this to the individuals and explain the more you expose to the less anxiety you will have each time. So these kind of SUDS ratings, they may not be so helpful here. They may be helpful just to get a way to get the individual started with the ERP, but it's also important to mention that habituation might not be as linear for everyone, and some will become better at suppressing tics while still experiencing the premonitory urges, and that might be good enough. We might not be able to really make all premonitory urges go away, even though they become more successful in suppressing their tics. So one aim of itself might be to just become better at suppressing tics. If you're working with children, which I believe many of you might be, one way to present the rationale about the tic suppression is to talk about brain breaks, that we're going to practice the brain breaks, and then you can point out that the brain breaks are here in the front of the brain. And the more ERP practice, the stronger the brain breaks become. And perhaps you can draw a parallel to physical workout. We need to practice much, or perhaps practice an instrument or something like that. This is something that needs to be done repeatedly to become really good at it. And the goal of ERP is to learn to suppress the tics for longer and longer periods of time. I mean, as I said, they might already know how to suppress the tics. So now we're going to do it a little bit more upscale for longer and longer periods of time when the premonitory urges are at their strongest. So at really difficult times, and also in various situations. So they're able to do it in school, at the bus, and not only at home or when very focused, sitting in front of the therapist or something like that. So we really want to generalize this to the everyday environment. So how do we do this? We can't, I mean, basically it's kind of this, I don't know if you've seen this comedy drawings of CBT where the only thing the therapist is saying, just don't do it. Don't do it. And that is kind of what we're doing here as well. But we're trying to do it obviously a little bit with some instruction. But there's no specific instruction other than trying to suppress the tics. So there's no instruction of how they're going to suppress the tics. So this is kind of like a mental thing rather than with a competing response as in HRT CBT. We want them to suppress all tics at once. And to make it a little bit more structured and perhaps also a little bit more fun, we're going to use a stopwatch. Every phone has them nowadays. And write down the high score times, especially if there's younger individuals. So try to break their high scores and try to suppress tics for longer and longer periods of time. And this response prevention, if we look at the Dutch manual, the purple manual that was to the right, they are supposed to continue with the response prevention until the patient is able to suppress the tics for approximately 15 minutes. Then we can move on and add the exposure bit. So exposure in Tourette's is not necessarily the same as exposure in OCD or for anxiety, where we want to expose for the obsession, the content of the obsession, or an anxiety provoking situation. Here instead we just want to make the practice more difficult by suppressing tics when premonitory urges are intensified, or by suppressing the tics in various situations. So what we're exposing for here is actually the premonitory urges. So we want to promote the premonitory urges, and then we want to practice to suppress the tics. So as I've written out here, to provoke the premonitory urges, that is what we refer to as the exposure, and the practice to suppress tics is the response prevention. So some of you may be familiar with the leading treatment for obsessive compulsive disorder, OCD. It's also called exposure and response prevention, ERP. Some say it's the same treatment as we're working with here. I would say it's the same name and vaguely related, but we're kind of working with some other type of practice in tics because we're not working with anxiety. We want to suppress, so we want to provoke the premonitory urges and suppress the tics. So that's one way. And then we also want to suppress the tics in various environments and situations. For example, situations where the tics are especially difficult to suppress, or the patient is especially motivated to refrain from ticking. So that's a way to generalize the practice and the training. Here are some examples of how to expose for the premonitor urges. The patient focuses on the premonitor urges and when they're sensed in the body. So the therapist asks the patient to try to where do you feel these premonitor urges? How are you feeling them? So to put words on this, more or less. Could also be that someone asks the patients about the premonitor urges and tics, was kind of what I just said. That someone provokes the patient's premonitor urges. The patient, him or herself, may be fully aware of how this can be provoked, and also parents and also perhaps siblings may be very well aware of how this can be provoked, and then by teasing or something like that. It could also be that someone imitates the patient's tics, kind of related to the point above, or that the patient looks in a mirror and focuses on the premonitor urges. So these are just ideas. I think basically ask the patient, the individual, for more suggestions. She or he will probably know how to increase the intensity of the premonitor urges. They're expert in themselves. They're experts in their tics. So you can try some of the points above, but at the end of the day, I think just have a good dialogue with the individual, and you will find a good way to make the practice more difficult. And here are some examples of situations, how to various situations where you can practice ERP to make it more difficult. But this is not exhaustive. This is just more or less an example of. This could also be an example of a list of fun things to do, more or less. So again, talk with the individual, see what things could be possible to do in the context of the therapy you're providing, and also as a homework exercise they're doing at home. If you want to make it really difficult exposures, here are some examples from one of my colleagues, Helene. She suggests to do half of the tic, to more or less start doing the tic on purpose and then stop halfway, or change activity during the practice, so to vary between active and passive back and forth, or do kind of like cognitively challenging activities at the same time, kind of reading backwards, doing maths while suppressing tics, or do activities that creates a lot of excitement. You remember that I said that excitement could be one of these factors that make premonitor urges and tics more intensive. It could be like playing card games like hijack, or other things where it's important to have a quick reactivity. If you wish, you could use an exposure hierarchy, a ladder, which is very common in anxiety treatment, or at least it was common back in days. I think where some newer research is moving a little bit away from these, but it's probably not super helpful in the tic case. You could just use it as more like a visual aid, so you can keep on track on what you're practicing, so you're actually practicing. But I don't think it's necessarily that important to do it like in a certain order or something like that. It's not that similar in the end to exposure for anxiety, but a good visual aid to keep on track in the treatment. A little bit about the treatment overview. The manuals, they instruct about 8 to 10 sessions, but obviously a patient should be provided as many sessions they need. If possible, some may need less sessions than this as well. In the beginning, it's every week, and later more spread out. And as in all behavior therapy, homework assignments are key. I will talk more about this in part 2, and also in the next slide, I believe. Since tics naturally wax and wane over time, as I explained, booster sessions may be needed, because it might be that you terminate treatment when they're at naturally tics have naturally waned, and then the patient is not motivated to work anymore. You do, as a therapist, and perhaps not have that many tics to work with in session. There's not that many tics to suppress, and then you decide, well, perhaps it's time to end the treatment for now. But then it's good to be able to offer follow-up sessions or booster sessions if needed, because it might be that you just hit the natural wane in the course of the individual's tics, so that they, in just a few months or so, or 1-2 months or so, they're at the new high, and are and then it might be good that they have an easier way into treatment, so they do not need to seek from the very beginning and through all the assessment paths and or however it may look like at your clinic. If we focus just on one session, obviously you would need to do some follow-up of the homework assignments and then provide new homework assignments. But I highlighted, made it bold here, the in-session ERP practice, just to highlight that the ERP, how it has been evaluated in studies, is that most of the session has been actual practice with the therapist in session, either at the clinic or out doing various things, like in the various situations, like in the list of examples I have. So I just wanted to highlight this. Do not forget that. Do not fall into the which is easily done as a therapist, to just talk about what they're supposed to do. Try to do it also during the session if possible. All these manuals also instruct what's referred to as social support. So that is the role of parents, relatives, partners, and that is to encourage the work with the treatment, to provide positive reinforcement and to keep them on track with treatment, but also to remind about practicing ERP, especially for younger individuals. Might also participate in ERP exercises and participate in exercises based on functional analysis, referred to as functional interventions. And I will talk more about functional interventions in the next presentation in next month, because this is something that can be added to both HRT and ERP. It's not really linked to that. It's just an overall way of using functional analysis, using behavioral analysis to try to change the environment in various ways, to try to make the tic severity less by actually not working directly with the tic symptoms, but instead with the environment around it. So I will talk a little bit more about this in the next presentation. We're approaching the end now with questions. Here are some myths about behavior therapy for tics that various studies have shown that the statements are more or less just myths. So, but this is what you might hear from families and others when you talk about Tourette's and tics and behavior therapy. So, for instance, if you suppress tics from coming, it leads to more and stronger tics later on. If you treat a tic, then it will move to another place of the body, kind of like playing, whack-a-mole at an amusement park. Suppressing some tics make other tics worse. Competing responses, as in HRT, they become new tics. Focusing on tics in treatment makes tics worse. That might be true, at least temporarily. When you start in treatment, you might start talking more about the tics and focus more on them, and then it might actually become worse temporarily, but that usually goes away. BT only works for mild tics, has not shown to be true, and BT makes other problems worse, has not really shown to be true. So you should be aware that this is what people may present, but studies have contrary shown that BT works for all types of tics, and these kind of side effects are not very common. Okay, summarizing today's presentation. So tics are common and often impairing. Tics are usually preceded by unpleasant premonitory urges. Psychoeducation should be provided to every patient that is diagnosed. And then there are several evidence-based treatment options. We have HRT, ERP, and also medication, which I did not talk so much about today. And ERP, which we're focusing on, the exposure is to the premonitory urges, and the response prevention, that is another word for actually suppressing the tics. Okay, so I think we're good on time. We're 5 minutes early. Perhaps I'll rush too much in the beginning, but if you have any questions, feel free to write them in the chat, and we have 15 minutes to talk about this. And then also, I think Julian said that you could answer the poll now as well before you leave this the Zoom talk here. So
yes,
very welcome.
Thank you, Per. I'm just about to launch the post-webinar evaluation now, so please do complete that if you would like the credit for that's on offer from the CPA. And of course, please post your questions in chat for Per to answer. Thank you.
Thank you. We have a question here from Anu. Do clients report physical fatigue or exhaustion due to tic suppression? What are they doing to suppress tics? What does it look like? Yes, I would say my clients typically report this, especially in the beginning while learning this. The whole idea with this is that it should become more automated while the more you do it. So you might be better at suppressing tics without actually thinking about suppressing them, or without it demanding as much energy. But especially in the beginning, clients do report this, and it's an, I would say it's kind of like an adverse event, a side effect of the treatment for sure. So if you have very young individuals and they're not really motivated to do this treatment, and perhaps not very impaired by their symptoms, their tics, you should be aware that it could also be an alternative to just wait and see, kind of like a wait and see approach, and see if it actually becomes more worse. Because especially some of the younger individuals, if they're not so motivated and not so impaired, they might not really want to do this treatment. If they start doing and practicing, they may become exhausted, and they may also become irritated, and become some conflicts in the family and similar. So I think since this is kind of like a treatment which works for which will not, it's not an incredible treatment that will remove all tics or something like that. It's more that we want them to increase their ability to suppress tics and have more like their own will, controlling whether they have tics or not in specific situations. I think it's important that they actually have some type of motivation and also some impairment from their tics to go through such a treatment. And what are they doing to suppress tics? What does it look like? I think in the beginning of treatment, they usually look very focused. So perhaps looking down at the table, and we cannot really be sure what they're actually doing. Some might actually do things with their body as well, kind of like, I don't know, closing their fists or something like that. But mostly individuals look very focused, but perhaps that's not the way to do it. But we want to get away from this in the long run, so you don't need to just sit and look down on the table. So that's why we also want to actually do it in various situations, to be more active and see if they can actually suppress their tics at the same time. Hope that was somewhat answer to your question. Thank you for that. Any other question? Here's a question, I think. Let's see. It's from, let's start with Sandra. Sandra, may I suggest that the younger patients ages 4 to 11 might not be at the development stage in their life to participate in ERP? Perhaps HRT should be a more successful approach to helping the patients control their urges and tic responses. I'm a parent with an 11-year-old son diagnosed with tics. Thank you, Sandra, for sharing this. There's no really evidence to back this up, so we don't really know. You see that we're a little bit limited studies on ERP, and there's not that many, there's no studies really comparing HRT to ERP, so we don't really know. But from my clinical experience and also talking to other clinicians, mainly in Europe, I would say that many of them actually use ERP for the younger individuals, perhaps not for 4, 5, 6 years, but at least from 8, 9 years and up. They definitely use ERP, and more commonly, as I said, in Europe to use ERP than HRT, and that is mainly because I think it's simpler to instruct in a way that and it's for some individuals they think it's also maybe more fun because you can use this timers and you can do the record times and high score lists and such. So I would not say that an 11-year-old will not be able to do this treatment. We've had a lot of 9, 10, 11, 12-year-olds in our studies, and they engaged in the practice and tried their best. So I would say around 4, 5, 6. That's perhaps a little bit young to be motivated and also have an understanding and impairment from their tic disorders. I would say that's more rare. But there is a study a pilot study on HRT for younger individuals. I think it was they were from 5 or from 6 years old in this study. It was made in the US. And if I remember correctly, what they did in this study was that they focused a little bit less on the HRT. This was a study on CBIT because that's how it's referred to in North America. And they focused a little bit more on the functional analysis and the functional interventions, things that parents and people around the patients could do, rather than that the very young individuals should use HRT. But it was a little bit of both. But I will talk more about these functional interventions in the next presentation. So that might be also something to be aware of and something that can be combined with either ERP or HRT. I hope that was answer to your question, Sandra. Thank you very much for that. And then Vanessa, thank you for your question here as well. How do you encourage or support clients to indicate that they can't suppress their tics or find it too hard to do? I'm thinking of children who may find the process difficult initially. It's a very good question, I think, and it's also the kind of link to the question: what if the individual do not feel any premonitory urges? How do you do that? Because that's kind of that's the whole ERP practice kind of based on that the individuals should actually feel a premonitory urge. But somehow my experience is that when you start doing this and you make it a little bit fun and such, most children, even the youngest ones, are actually possible to suppress their tics and when asked to do it. So and if they have many tics, so they might be able to at least suppress one of them. They might not be aware of some of the smaller ones. Some individuals may not be aware of the eye blinking tics, for instance, because they're so automatic and they blink. Everyone blinks anyway. They just do it more often and such. So one way then might be to focus on 1 or 2 of the tics that are more impairing, and perhaps larger tics, and to see if the young individual may be able to suppress like an arm flapping or shoulder tic or something like that, or certain vocal tic or something like that. So that might be one way to kind of divide it and focus on some of the tics and not the other tics, because what we want to do in the end is just want to learn a strategy to learn them to feel that a tic is coming and that they can actually control it somewhat. I'm not saying that they can control it completely, but they can at least increase their control somewhat. Very good question. I'm not sure I was able to answer it fully, but I tried at least. Let's do one more here. We have from Anu here. Can relaxation and breathing other activities be used during ERP? Yes, relaxation training is usually used as an add-on to HRT treatment. That's one of the parts of the CB treatment. It's the functional analysis and interventions, it's the HRT, and it's the relaxation training. So I see no reason why it could not be added to ERP as a way, but I would group it perhaps with this functional interventions, because then we want to try to do something with the environment somewhat. So a short answer, there's more questions popping in here, and we have 4 minutes to go, but I would say short answer is yes, it can be combined, and it is usually combined at least with HRT. So I have a client, so Poonam here, thank you for your question. I have a client who was exposed to bed bugs, and now she has extensive itch urges even if bed bugs are not there. Can this be applied in this case? I don't know. I mean, it's if she doesn't have tics otherwise, if it sounds more like this is perhaps something that is classically conditioned or something like that to the bed bug situation, perhaps more like kind of like an anxiety linked thing here. Very hard to say with only a few minutes to go and not knowing more about this. But if the patient also has tics, like traditional tics, then perhaps it might be applied. But I'm a bit uncertain. I hope that was at least partly an answer to that. Let's see here, Sander. Thank you. Are there any long-term follow-up studies to evaluate the effectiveness of ERP over time? If so, what factors do they suggest may be responsible for long-term effectiveness? No, the only study that has a long-term follow-up of ERP, it was actually published today, and that is the long-term follow-up of the UK Internet ERP study, and it was published today. And I don't remember exactly the journal, but if you search for Chris Hollis, Hollis, and ERP and tics, you might find this study is freshly published, and they show that it was actually the results were maintained over time. But I think this study did not contain any analysis of like the exact mechanisms that were responsible for this long-term effectiveness. I don't think this design actually allowed it, but they showed at least that the effects were okay maintained over time. It was a 18 months follow-up or something like that, like about 1.5 years after the end of treatment. So we have the last question now from this year here. School spoke to me about the case of a grade 8 male student with history of behavioral issues. He has newly been diagnosed with Tourette's and has started swearing in class and saying racial slurs. They say there is a female student with dark skin in the class he never liked, and they wondered if that was a coincidence. He will sometimes say things like, "I'm allowed, it's my Tourette." They wondered if there's a way to say if he might be exaggerating his symptoms at times. That's a really good question. I mean, in a way, if he actually has Tourette's and tics, and saying this is very, very good, obviously, to explain that this is Tourette's so he doesn't run into problem. And also, but I mean, you could have Tourette's and also say stuff out of free will if there's someone that you do not like or something like that. So it's really hard to separate without having more information. It could be a little bit of both, of course. But is this a student that is with a normal IQ and normal goes to a normal school, or are there some okay, really difficult. I mean, I guess this needs to be one way is obviously to discuss this with the individual itself. I mean, they're usually, from my experience, individuals are usually quite good at separating when tics are tics and when tics are just tic-like behaviors, if to call it that way. And parents might be uncertain when they swear like this. Could that be a tic? But when you ask the individual, they're pretty certain often what is involuntary and what is not. So I mean, it's really hard without having more information. But I mean, you should not rule out that it could be a little bit of both at the same time. Sometimes it could be these automatic slurs, and the other times it might be a little bit more because he's in a certain situation.